day, I suddenly see everything in two, and I can see people with two heads, and everything was so confused because the road is one road, but it comes as two in my sight.
Hi, in this episode, you get to meet one of my patients who presented with double vision. Now, he's working very hard. He's a graduate student / postdoc here in America, and he wants to prove himself. He's working on very challenging nanoparticles. And while he's working, he realizes that something's not right. He's developing double vision. It's become very clear, so he goes to the emergency room. When we get a scan, he originally is thought to have a common tumor. A common tumor, which is a 1 in 1,000 tumor, is a pituitary adenoma. Extremely common, and they're pretty routine surgeries. However, in his case, we find a 1 in 1,000,000 tumor. This is a Clival Chordoma. Now, this tumor is something that I specialize in, and fortunately, even though this is such a rare tumor, you can imagine it's a 1 in 1,000,000 tumor incidence in the United States, so only 300 are being diagnosed every year. So fortunately, he comes to our hospital, I see him, and I'm able to provide him with excellent surgical procedure, which then results in complete resolution of his symptoms.
My name is Hyun-ho Kim. I am a postdoctoral researcher working at Drexel University. From this year, I was on a new project, and I worked really hard, let's say every day. But at some point, I noticed a severe headache in the morning. And then after nearly 3 weeks, one day I suddenly see everything in two, say one object in seeing as a two object, and I can see people with two heads, and everything was so confused because the road is one road, but it comes as two in my sight. So what happened, I think, is that the image that comes from my left eye and the right eye couldn't be somehow processed into one image, so I thought I was just not able to focus on the things on the far object, far distance. And however, it turns out something really scary was happening. So I visit ER.
So my patient has a very rare tumor. This is a chordoma. These are very rare, 1 in 1,000,000. So the fact that he showed up to the emergency room and just presented with this is pretty unusual. Now, in contrast, a tumor that I see very often is pituitary adenoma, is 1 in 1,000. So you can see this is 10 to the 6th, whereas this is 10 to the 3rd, so it's a big difference in incidence. And when he came to the emergency room, we actually thought it was originally just a pituitary adenoma, but I really want to thank my radiology colleagues who reviewed this very carefully and showed clearly that this was a chordoma. So going into the operating room, I was ready for that. So why is my patient getting double vision? I think it's important to remember we have two eyes, and the eyes have muscles that are pulling them. You have the superior rectus, lateral, inferior, medial on both sides, and although there are 5 muscles, because there's also superior obliques, there are 3 nerves, 3, 4, and 6, 3, 4, and 6 on each side that supply the innervation to these muscles. So the classic nerve that gets affected when you get horizontal double vision, which is where you see 2 images side by side, that's because these eyes are not fusing properly and seeing the images. It's usually damage to the 6th nerve, and that is very classic for clival chordoma. So in this case, the 6th nerve feeds the muscle that pulls your eye to the outside, so this is the lateral rectus, and so if this 6th nerve is damaged and it's innervating this lateral rectus, when this eye tries to move out that way, it has a problem, and now you don't have fusion. So this eye can move properly inward towards your nose, but this eye cannot. And so that's exactly what my patient's having. He's having lateral rectus palsy from 6th nerve injury, and it was pretty obvious when I met him. We talk about the brain and the cerebrum, and then the cerebellum. But what is important also are the nerves that go to the eyes, and one nerve in particular. So it has the pons and the medulla, and there's a very thin nerve that comes up very long distance. It starts at the cerebellum medullary junction. So if this is the pons in the brainstem, it travels very far up before it goes into the cavernous sinus, and that nerve is particularly sensitive because that's the sixth cranial nerve that can cause the double vision in this case. Now, just under here we have the pituitary gland, but pituitary tumors rarely cause a sixth nerve palsy. They can invade the cavernous sinus and cause problems, but in his case, he has a big tumor that's essentially, fortunately, started in the bone, but because the nerve goes in through Dorellis canal into the cavernous sinus, it's easily affected, and this is his clival tumor that's causing his problem. So I'll show images of that, but his eyes and nose are here. So the classic way to remove this, the old-fashioned way, which we don't do anymore, would have been mid-face incisions, but in this case, we're going to just go through the nose. I'll work with my ENT colleagues, and fortunately, these tumors tend to be very soft. Because it's soft, I'm able to just remove this entire thing without difficulty, and it relieves the pressure from his sixth cranial nerve, and he has immediate relief of his symptoms.
So I visit ER after getting the advice from urgent care, and then I visit ER in the evening. So they were initially, initially thinking of something happened with the nerves. So I got a CT scan, and then I was admitted to the hospital. And later on the next day, I had another MRI scan and the CT scan. And then surprisingly, I was sent to an operation room like within like a half day after just sleeping at the hospital. I was just not ready, and it was so much to take because I just thought I am just tired, but the scan result to say I have something big in my brain or in my head. And then, okay, and after we do MRI and CT scan in the next morning, I expected to go to the room back, but I was sent to another area. There is like a pre-operation space, and then one part of me was thinking like, oh, I am not ready for this, and on the other hand, I was thinking that like my surgery was involved with Dr. Lee and also Dr. Rajesh from ENT and many others from other department. And what I thought was that the doctors are trying to do this very quickly. So I thought it is a really urgent situation. And then there was like nothing to consider further. So I just asked, please do whatever is possible on me. And then surprisingly, okay, my surgery was done, say within 24 hours of a ER visit, and then right after my vision comes back. So I like to say, if anyone feels double vision, say 2 images from 2 eyes are not overlapping well, you need to go ER.
This is a good opportunity for me to show you how we do advanced endoscopic endonasal surgery here at Penn. The way I like to do it is I have my ENT colleague stand on the patient left, I stand on the patient right. In this example, the patient is lying down and they're facing up, and the camera is located at the patient's foot. So we're looking down on the patient, and my ENT colleague and I are looking through up into the patient's nose and then looking on the 2 monitors. This allows us excellent access, and in this way we're able to do excellent complex endonasal surgery. Now, this is not Mr. Kim, and this is not Dr. Rogers. Yeah, your story really resonated with me because we are both Korean heritage. But I asked him, "Do you have any family here?" And he has no family. "And do you have anybody that I should contact?" And there was only your one friend, because you've only been here how many months?
It's been like 1.5 years.
1.5 years, and so that was really. It helps me to appreciate how much trust he has to have and put his faith into me, and The other amazing thing is that his tumor is not a common tumor. Initially, there was some suspicion that, oh, it's a very common tumor, but his turned out to be a very rare tumor that I actually happen to be an expert of, and I just he happened to come to the hospital where I'm at. But this is a rare tumor. So his presentation with the double vision is actually quite classic for this tumor. So not everybody who has double vision has this tumor, but if it is the tumor, sometimes we can take it out, get everything out, and improve the vision right away. And how many days did it take where you noticed the vision was better?
Just right after the surgery.
Yeah. See.
So once I wake up from the anesthesia and from the surgery, I noticed my vision comes back perfectly.
Yeah, it's really remarkable. So I want to thank you for having the trust in me and the courage to do this surgery. That was really impressive. All right, well, very good.